My name is Tang, and I appreciate you letting me address you for a few minutes. I spoke with Dr. Cho the other day. He suggested I might bring this to your attention. And if I could, I'd like to talk about it in two settings. One, I've got 8 copies of this proposed protocol here, and I understand there's like 8 trauma centers. We can just pass them around. My background is in emergency medicine for the last 30 years. I see a lot of familiar faces. I've worked with a lot of you at different hospitals in this area over the last 20 years. I am currently at Eisenhower, which is not a big trauma center. We don't see a lot of trauma unless they're right at the gate. And anyway, so trauma wasn't the real issue for me at the hospital, but I've been part of that tactical group for 18 years now with law enforcement. I was part of the group that was put together the guidelines that are put out by MSA. And just in relation to the combat gloves, we didn't put it in there until they took the heat out, because it was a big problem in Iraq. It was burning people. And so now they've gotten it good. They've got it good for now. But with the tactical field, one of the issues has always been for me is how do I buy some time to get that patient to a trauma center? Particularly with my officers, and our concern is usually penetrating trauma, bullet wounds, abdominal wounds, chest wounds. And as all of you have been in this setting where we have been unable to help somebody as they just bled out in front of us. And so I was looking for a way to buy time. And it kind of came about during a physiology lecture one of our instructors was giving. He's an anesthesiologist from Mayo Clinic, and he was talking about the physiology of shock and issues about, Starling curves and a lot of the basic science of it. And one of the things that occurred to me is that, well, we have a couple of things in our trauma pack that can help us in that setting. One is something called a SWAT T, and this is a type of tourniquet that we use. You just wrap it and stretch it, wrap and stretch. You put about 8 wraps, and that will stop any leg bleeding, so it acts as a tourniquet. But many of you who've ever been in orthopedics will recognize this as a copy of the Esmark dressing that was invented 100 years ago. And Dr. Esmark used it to squeeze all the blood out of a limb so that you could do bloodless surgery. It's still used today. They use an Esmark dressing, they squeeze the blood out of the leg, they blow up a pneumatic tourniquet around the thigh, then you put the leg back down, you take the dressing off and you scrub it up, and there's no blood left in the leg. And there actually is some blood left in the leg, but the interesting thing to me was that blood left the leg and went somewhere. And it had to be in the core circulation because it wasn't out on the street. So from my point of view, that blood is now in the vital organs. And this, with the tourniquet, became kind of analogous to cross-clamping the aorta. The first thing we do when we open a chest is scoop out the clot, cross-clamp the aorta, because we want the blood, the limited blood supply, just to go to the vital organs to try and save this person. So it turns out that you can cross-clamp the iliacs to the legs, and you can make the legs ischemic for 2 hours with 0 morbidity. I mean, there are over 300,000 cases done in orthopedics. It has 0 morbidity. So once you go past the 2 hours, you start to get some problems, compartment syndrome, nerve damage, things like that. So we had the equipment, this and a tourniquet just like that. We had the equipment to do that, but when you do it, it takes 2 people. You got to hold the leg up. You got to start wrapping it down here. It takes about 10 minutes to do it. And in fact, it does work if you're in a pinch. But I got online, and this is about 2 years ago, and I started looking to see, well, what else is there? And it turned out this Israeli emergency doctor had patented a device that he called the HemoClear, and he called it the HemoClear exsanguination tourniquet. And basically, his field was looking for orthopedic, and he has a minimal penetration. He's trying to penetrate the orthopedic market for orthopedic surgery because this is a throwaway. It's one use, sterilized, throw it away. There's no extra equipment. You don't need power. They sent a whole bunch of these down to Haiti during the earthquake. It was a big success. When you don't have the luxury of electricity, you don't have a pneumatic pump. So I'm passing one of those around. The way this works and this is a smaller one here, but the way it works is you put it over the toes or the hand. There's a small one made for the hand, and then you just pull on the handles, and as you pull the handles, it basically wraps this downward, okay? And once it gets to here, there's no blood flow going into the wrist. So it has some applications, the emergency room. I had a guy with an arterial bleeder the other day. And with one of these, you just pull it down in 8 seconds and stop the bleeding. And I have a, essentially a field I can work on that. So the small one is made for arms or children's legs, and the large one comes in different sizes made for adults. Now, where this came from, historically, it goes back a long ways, where they invented these tourniquets a long time ago to stop the blood flow so that they could work on people. And this is one being put on in the operating room, actually in Israel. But they're being used in America. It's an FDA-approved device as a level 1 device, meaning low or no risk. Okay, they cost about $75 to $80 a piece, and they're a single-use throwaway. Some of the issues that come with this, first of all, I mean, there's some nuclear evidence that show that, in fact, when you squeeze the blood out of the leg using things like mass pants or some of these Esmark dressings, you actually leave about 35% of the blood in the leg. One of the problems with leaving it in the leg is, and this was an old type style one, I don't know if any of the surgeons remember this from years ago, the Rice-Davies exsanguinator. But when you leave blood in the leg and you put a tourniquet on, which we for years we finally got around to using tourniquets in this war after they were finally accepted when we looked at Vietnam data that showed that people were dying of extremity wounds. Now every soldier has a tourniquet, like one of these little cats, just like you see here. A lot of the soldiers still have problems where if you're in a Humvee and the doors are blown over, you kind of can't get your equipment off and you can't put things in. There still have people bleeding to death. But it was a big step forward to put a tourniquet on. But when you put a tourniquet on, particularly for any length of time, what's going to happen is the blood's going to start clotting. And it's going to form lactic acid and clots, and then the minute you let that tourniquet off, it's going to shovel those into the circulation. They're going to head north and lodge in the lung. And in fact, they have a lot of evidence showing that that these do end up in the lungs, both by ultrasound and by nuclear studies showing that you get lots of microemboli. There's also a fairly high risk of getting cerebral emboli through what's a little hole called? Patent for foramen ovale. And they shoot through there and it's on your head. There's a fairly significant risk of that even after knee surgery. So there are some risks of that, and it's because of leftover clots. So what you'd like to do is actually exsanguinate the limb before you put the tourniquet on. And that has the added advantage of now the blood's in the core, not sitting out in the leg, clotting. And I'm not here today to ask your blessing on this, and please put this in your protocols. I'm only telling you about this because I'm trying to do a study on this, and the study is going to involve hopefully getting into the pre-hospital market, and you have some input on that because we're looking at shock patients. All right, so I want to tell you about the mechanism, how it works, the advantage of how it works. I will tell you that when you see this, and maybe you look at your own situation, whether you're a surgeon or whether you're working in an emergency room, and I think you might see places that this will be a benefit to you. And it's available now. It's an orthopedic device, and so we can use it for off-label things. I actually, these are contraindications. You don't put it on a leg with a DVT, a malignancy, an infection, severe burns, they're going to rip the skin off, compartment syndromes, or bad circulation because you're making ischemic. But the trade-off here is that dead people don't get any of those things. So if you're trying to save somebody, it's a trade-off. I will tell you that I got these in. I was thinking this is interesting. I'll carry them in our pack, see if we need them, because this will buy me 2 hours of transport time to get to somewhere where there's a trauma surgeon who can help the patient. So why does it do that? It does it for 2 reasons. One is it turns out that if you squeeze all the blood out of your leg, there is about 500 cc's of blood in an adult male in each one of his legs. So that's 2 units of whole matched, purely matched blood with all the clotting factors that is now in the core circulation. And maybe some of you have been in the situation where you thought, God, if I could just get some blood in this guy, I might save him. Well, here's 4 units of pure blood that's matched this patient that's sitting in his legs. So I'd like you to think of the legs as a reservoir. And this isn't just for a bleeding leg that you put on the bleeding, and it will stop the bleeding, because when you put it on, it squeezes all the blood out, and then once it's above here, it tourniquets the leg. But each one of your legs, supposing you're bleeding in the gut, and each one of your legs has 2 units of whole blood, and you push that up here, and now you've auto-transfused the patient. That's why it's called an auto-transfusion tourniquet, right? The second thing, and I think possibly the more important thing, is you're now cutting the legs out. You don't have to perfuse them anymore. That's 40% of your cardiac demand, output demand. So now you've essentially cross-clamped that circulation to unnecessary legs, and you're circumventing that, pushing it into the core. So now whatever you're doing is going to be more effective by 40% in terms of perfusion. So I got this, and I thought, well, it's interesting. This is what it looks like inside. There's a silicone ring. It's essentially web roll with straps that go down, and they're rolled up. That's the key to making it come up. It turns out the web roll is actually essential here, because if you take the ring out of this and you roll it over your wrist, it doesn't have enough tension to stop any blood here. So as you move it up to the point it would, you'd be trapping all that blood down here. So in fact, the webbing down here, which lots of rolls, has enough pressure to squeeze the blood out, and as you leave webbing, as you roll it up, when you get up here, it's just the ring that's causing the pressure. So it's actually kind of an ingenious design, because it's needed for that. I got some of these, and I just want to tell you that a lot of people say, well, isn't this just mass pants? Well, sort of, but mass pants, some of you will recall as being very good devices that we all had, and you saw them very successful. Others will say, well, they never worked. In fact, they were level 1 and 2A recommendations of the Heart Association with certain things, but we threw them out anyway. So we don't have anything like that anymore. But in fact, they did do some things. They didn't do it well. They didn't squeeze all the blood out of the leg. They left like 50% of the blood in the leg. They also changed with the barometric pressure, so you got in a helicopter, pretty soon it swelled and went down, and all of a sudden the arterial blood was going in, but the venous blood wasn't coming out, and you're trapping blood, getting more clots in there. They came off all at once. So if you think about the hemodynamics of this, if your patient is already down 20 or 30%, and you have these on, and then you pull them off, so he suddenly dumps a liter of his blood into his legs, he's going to die. He's going to die right in front of you, because you're suddenly going to take 50% of his blood volume, dump it. So there were reasons it didn't work. There's still some reasons that that it is still useful. Bookend fractures of the pelvis, AAAs that are ruptured, they're still indicated, but nobody has them anymore. Is that right? I don't know where they went. Anyway, so there's 2 things that this does. One is it returns all the blood to central circulation, 4 units of whole blood. Secondly, it blocks re-entry of blood to the limbs. That's the tourniquet effect. I will tell you that tourniquets finally have become sacred in the military. So we actually have the military, the SEALs are taking these to Afghanistan. They're actually over there in the ortho field already, but they're not out in the field where they can really save some lives, and they are actually taking them over this month. This is how they go on. You roll them on the toes and you pull them up. You can put them on yourself. You can put it on by yourself. It's something that if you were bleeding out and start to feel faint, you can essentially auto-transfuse yourself. You've got 2 hours before damage starts to the leg, but it's going to start hurting. And so those of you who put a tourniquet on, suddenly realize it's going to hurt. I will mention one thing is those of you remember how to do beer blocks, which was you put on the tourniquet, then you put in some lidocaine, it seeps up around here, and then you move the tourniquet down to the numb part. This works great for that, because the minute it gets up, you just roll it down a little bit, and now it's not going to hurt at all. So there is a lot of uses that you pull it up, and then you tie them in place. This just shows that the foot is pale, there's no blood in it when you pull it up. This little blue one that you have here, if if you roll it up to your wrist, that hand will totally blanch because there's nothing in it. It's obviously going to be useful in shock, and I will tell you that I think it is a mechanical thing. It works in all kinds of shock. That's what's really beneficial about it, whereas you may know that epinephrine, which only got a study to prove it worked this year, doesn't work when you're acidotic, and so the worse the patient is, the more you pump in there, it doesn't do anything. And the same with vasopressin, doesn't work in acidotic states. So this is a mechanical thing. It always works. It always squeezes it, and it doesn't matter if you're hypovolemic because of anaphylaxis or dehydration or hemodynamic problems or probably even sepsis. It's always going to have the same mechanical effect. One of the things I will tell you that I think it also has a use in is cardiac arrest. There's an annual conference, an invitation conference called the Wolf Creek Conference out in Palm Springs. It was hosted until this last year by Hal Weil, and he died last July. But every year he would have this conference where the basic science people would come out and present their research. One of the big issues that goes on in CPR is the lack of venous return. You're pumping an empty heart, and because of that, CPR is very ineffective. We all know that. We also know that our survival to discharge is dismal. It's 4%, 5%, 6%. That led 3 years ago to a guy in Minnesota named Keith Lurie, who took the toilet plunger idea and patented a device, which he's going to try and do a study out here very soon, where this suctions the chest and pulls it upward. That causes an increase in negative pressure, more venous return. He did a study back east with 2,400 patients, and he improved survival to discharge by 50% of the group. So it went from 6 to 9%, still not much. This is an active way of pushing it in. Okay, so let me cut straight to the chase about this. What I got some of these in, and they sat on my shelf for a long time until I got a chance to use one. And the first case that we tried to use it on was a splenic artery aneurysm that was bleeding. The woman had a hemoglobin of 4, a pressure of 40. She was fixed and dilated. She had a belly full of blood. And the bottom line is we gave her 2 liters of fluid, which was a dopamine drip. She got 5 units of blood, 2 platelet packs. Pressure was 50. We couldn't get her stabilized to get her to the OR, essentially, to get this fixed. And the bottom line is that the doctor said, well, we've got these things, let's try this. Put one on each leg, pressure went, boom, 100, just like that. And it stayed 100, got her up. Then they decided to go to interventional and futz around for a couple hours. But the bottom line is, at some point, the pressure came up, the dopamine was turned down. They then lowered the stockings, these things, down to above the knees. The pressure dumped to 50. They rolled it back up, pressure came right back up. So it went on. It's like an on-off thing that you can titrate, unlike mass pants. Patient finally got to the OR. They took out her spleen. She survived, and she walked out of the hospital 5 days later with a foot drop. But the foot drop was because it was on for 4.5 hours instead of 2. So it works. That to me was analogous to a gunshot wound to the abdomen with some kind of arterial bleeder. And that is something that buys me time to get to a trauma center for definitive care. Now, secondly, another case, I tried it on 2 AAAs, worked, it was a home run. I tried it on a number of other cases. They died, they were still dead, even after I finished with them. But I decided, well, I should try this on a cardiac arrest because of this empty heart problem. So I got a 60-year-old in who was failed the 3 rounds of drugs in the field. They're bringing him in, he's in PEA, no pulse, they got intubated him. And they were pumped around, they're just about to call it. They're saying, well, anybody got any ideas? Well, can I put these on his legs? So I put one on each leg. We pumped him around for 1 minute, and boom, came back to V-tach. Shocked him into V-fib. An hour later, got an echo on him that showed a normal heart. Okay, so here was a guy that we were calling dead who had essentially a normal heart. So there's going to be a place for this in CPR, in cardiac arrest. What I'm trying to do with this study is I kind of lump these things. And the reason I did is because I'm trying to think that a paramedic just looks at the patient's shock. He's not going to say, well, is this hypovolemic shock or is this some other kind of shock? Should I find the criteria? It's just shock. So I want to just put them on. So I was going to initially do this just as a study in our hospital, in the hospital, on people who were about to be called dead. And what happens, I had to go to our IRB. The IRB makes me jump through hoops. I got to go out to the community, get consent, because it's an emergency research. So I had to get a new IDE, yada yada. Anyway, the bottom line is, with all this work, I might as well go straight to the field, because that's where you're going to do the most good. So I wrote this proposal. We're waiting for the IDE to come from the FDA. I gave a copy to Umberto. I'm hopefully going to present it to the state directors meeting, and I'm telling you about it because for a couple of reasons. One is I'd like you to think about pros and cons if you have any issues with it. Number two, if you see a patient come in with these on their legs, don't cut them off. Just they have to come off slowly. It's like that mask pant removal. Now the advantage of these is, unlike the mask pants, you can cut the webbing off. You can cut that off. You can have the whole leg. The only thing you got to leave on is the ring, and then gradually bring it down, stabilize the fluids, make sure they're transfused up, correct the bleeding problem, whatever you need to do. I think that this is going to change how we do CPR. I also think it's going to change how we do shock. It's definitely going to change things in the military. You know, most of the time we're thinking about transport times that are, you know, relatively short. But there are people, I see it on the news every day, that bleed to death because they were 2 hours away from somewhere. This could buy them time to get help. It could buy a police officer time if he's bleeding from his own, from a wound, he's getting ready to pass out. He can put one of these on his leg, get back in the fight. So, you know, it has a place. I'm not sure it's going to be everybody or anything, but anyway, that's what it's about, and I appreciate your attention. Anybody have any questions about it? Yes, sir.
I think it's very interesting. I think there may be a lot of patients that may benefit from it. Now, there may be a lot of patients where it may actually be detrimental.
That's the question.
And once you start using it, you know, in the field, and where the criteria may not be so clear, and we may run into a lot of trouble. A lot of patients that, you know, may end up having this device for longer than 2 hours and have, you know, ischemic complications that maybe it may do more harm than good for the person.
That's why it was sort of easy to start with dead people.
Right.
You know, they're dead, now they're alive, and you know, nobody can argue with the risk there. It's also easier to go to the military because you're dealing with young hearts, congestive heart failure, et cetera, et cetera. But you know, I agree with you. When you put it out in the field, you're taking all comers.
Right.
So you know, the question will be, what is the trade-off in risk and benefit? If I cut the age down to young people, there's a better chance they're not going to have the cardiac problems and things. There are other risk factors like PEs from DVTs and things that have to be weighed into it. But you know, I'm looking at people I think that would otherwise be dying in the field. I've had some surgeons in our facility who, you know, have gone up to the OR like to do a AAA and talk about, oh God, this is going to go bad, and you know, and yes, we'll take these with you, because if you're in that setting, you may find that 4 units of his own blood may be buying you enough time. You know, I've always been in this thing where, you know, we see people bleeding out of garden hoses, and we're putting little straws in to give them blood, you know, with pressure pumps. It's never kept up with the bleeding. This, to put on, takes 10 seconds for life. So in 20 seconds, you get 4 units of blood. And you know, and it doesn't have to be, you can do one night, see how it does, things like that. You can titrate it, you can lower it, keep a permissive hypotension if you know. So there's a lot of, you know, fine tuning that can be done.
I like the concept. I think it definitely needs some study, but I like the concept.
Yeah, I think it's the mass pants without any of the problems. You know, it's kind of all good right now.
So,
Yes, sir.
David, you said you approached IRB.
We have an IRB at ICEM.
Yeah, and they've are pending approval.
They're pending approval. They want me to get an ID, investigational drug or device exemption. You know, why you need that for a class 1 device? I don't know. It has only to do with consent.
Yeah.
They've never done emergency research before. Emergency research, you cannot get consent. You know, so I have to go to city councils, I have to present it to them, and say, what do you think, people? And, you know, and again, if I'm looking at otherwise dead people, it's a no-brainer. And once we go out to the field, now we're talking about a different setting. And I think your comments are good. I mean, you got to weigh the benefits and the risk.
So I think you also mentioned you're going to MDAC and their scopes committee for.
That guy suggested he
That's-
present it to us.
So they can actually grant you a trial study, usually 18 months. But if you, and I hope you do, have the intention of ultimately publishing the results, I think IRB approval is going to become essential.
Well, maybe you can help me out on this, because ours is, inpatient, they've never done emergency research. I think they're a small IRB. The next step, this is a phase 2 study we're trying to do. What we'd like to do then is do a phase 3, and I have like 4 trauma centers around the country that are willing to buy in on that. But I think I have to go to a real IRB, like Western IRB, or somebody who has more standing than ours.
Yeah, and
Do you agree?
actually, this institution has an IRB we've used before that might qualify for. You
So
just
that,
get-
so Mayo Clinic would say, okay, you're IRB, we're good with that.
Or it depends on the target publication. That's kind of where we found out with previous studies. We did a Zofran trial, and for publication, we ran into that challenge. It was, we ultimately, the IRB here has helped us out, and they accepted that IRB approval. So I think there needs to, particularly because of what you just said about consentability, we often want IRB to look at and make sure there's no evaluating China, that this is not a harmful process, that this, like you pointed out, these patients are already dead. They may only benefit from this trial, or there's no consideration for harm to the patient that requires consent.
Well, as trauma surgeons, do you have any feelings, comments about what this is? I mean, I thought a lot of times, like when you bring somebody in, they're at a point where you're going to operate, they're going to get better, or they're going to die. And we're in the process of trying to get them to you. And whether they're in the ER or whether I'm out in the field, I need to buy some stability so that they can make it to definitive care. That's what I see this process is doing, and particularly for my police officers. Don, what do you think?
In the pediatric world, we probably don't have this situation a lot.
They use these in pediatrics for ortho.
Not for ortho, but in the trauma setting. And like we were saying, the whole concept of permissive hypotension is good in the military. They give them a certain amount of volume, that's it. It's kind of like a
Right.
one shot bolus, and then that's it. So you have to be a little careful about, you want them to have blood.
We don't want them to just turn around and put one on each leg and hit the hospital.
So the question is, how do you get the experience out to be able to fine tune it, know what you're doing? This is something you'd want to be,
Right.
there's a select number of people that are using it.
Do you see this as too complex for?
Now, the application is incredibly simple,
Yeah,
the
very.
concept is, intriguing. It's as usual, the execution of the plan that gives us the details on how you apply it in the setting that you do it, you have to be a little careful about that.
Okay.
Conceptually, it's an intriguing idea.
Yeah, I thought so.
That for writing a pre-hospital protocol, I mean, you would really narrow your parameters to, like you said, to young, healthy, otherwise healthy, take the 20 to 30-year-old crowd, and that's it for pre-hospital. You could narrow it.
Or dead people.
Or dead people, right. But even then, we could narrow our dead people parameters, and then when you get to the ED, you could have a different parameter. But for pre-hospital, you could have a very narrow parameter.
And somebody else was saying that probably, especially the trauma committee, wouldn't buy off on lumping everybody in there, CPR or everything else. But it's really hard to get the numbers if you narrow it down.
Yeah.
Well, that's predominantly our patients are predominantly, well, the hemorrhagic, I mean, that's trauma. But you've got the group that is the, 15 to 54. That's a huge of our population. And then we have the senior citizen fall